coming, everyone, especially as it's so cold. This is Declan Costello. Before we get started, just two things. Next week we're holding auditions for our Stanislavski workshop for singers. If anybody is interested in either attending or applying for audition, just send me an email. If you don't have my email or phone number, just see me afterwards. I've got some cards with me I can give out. In September, Roddy Williams has asked me to produce a course for him based on concert singing, so oratorio repertoire. Likewise, if you're interested, just see me afterwards or send me an email or a text message. Over to you. Thank you.
Thanks, Julian. Lovely to see you all. My name's Declan Costello. I'm an ear, nose and throat surgeon and I'm a singer. It's nice to see some familiar, friendly faces. Welcome all of you. I'm going to chat to you for about the next hour or so about vocal anatomy and vocal physiology. I'll also touch a little bit on some things that can go wrong with larynxes and perhaps a little bit about how to keep your larynxes healthy, your larynges, if we're going to be accurate, healthy. Say a quick hello to St Blaise, the patron saint of the throat. St Blaise, whose saint's day is on the 4th of February, coming up. You will... If you've ever sung at Westminster Cathedral on St Blaise's Day, you'll know that you will have your throat blessed with a pair of crossed lit candles, potentially quite treacherous. St Blaise was martyred in a particularly unpleasant way, but actually on the way to his death, he saved the life of a young boy who was choking on a fishbone, so the story goes. And this is a statue that until a couple of years ago was in the lobby of the Royal National Throat, Nose and Ear Hospital, and is now sitting in a warehouse somewhere looking for a new home. So there we go, St Blaise. Just a little bit about me. I mean, I have a background in music. I did a music degree at St John's, Cambridge, where I was a choral scholar, and halfway through the music degree realised that I wasn't going to make it in music, and realised that I wanted to do medicine. And in fact, both my parents are medics, so it looked like I was going to do medicine when I was at school, and so I took a little detour around music towards medicine after that. So I ended up studying for a total of about 8 years, which was pretty hard work, but then came through to medicine. And clearly within medicine, working with singers is great. It's a great privilege, and I still do a reasonable amount of singing myself. So I'm going to talk a little bit about top tips for a healthy voice. We can talk about some of the sort of specific conditions. We'll talk a little bit about if you have a sore throat, is it okay to sing, that sort of thing. And I needn't bore you with what's wrong with smoking, but I can give you some ideas. So, a music, and actually interestingly, I mean, I've spoken to groups in the past and just blithely said, oh, there's no way any of you guys smoke. And then afterwards, spoken to their teachers and their choral directors and absolutely astonished at how many of them actually do smoke, but I think it's getting less common. So let's just talk about the voice as a musical instrument. Any musical instrument requires three fundamental components. It requires an energy source, something that's going to make the whole system vibrate and produce sound, and in a violin that's the bow. It needs something that's going to vibrate to produce sound. In a violin that's the strings. And it needs something to resonate and give a broader quality to the voice, to the instrument. In the voice, clearly the thing that drives the whole thing into motion is the lungs. The things that vibrate are the vocal folds, vocal cords. You're going to be seeing a number of these photographs as we go along in the next hour or so. So let's just quickly orientate you. This is a photo taken as if I've got a mirror at the back of my tongue. So you're looking directly in, and so the bottom of the image is the front of my throat. Top of the image is the back of my throat, and then that's left and right. And the vocal folds, the vocal cords, are these two white strips, right and left. And when you're breathing, the vocal cords are apart, and as you'll see on a number of videos in a second, when the vocal cords come together, they produce sound. We'll talk about why they're called vocal folds as opposed to vocal cords in just a second. And then you need something to resonate and produce, to give brightness and other qualities to the voice, and we'll talk about the resonating chamber in a minute. So you've seen this photo already. This is the pictures below are a coronal section, so it's a slice in that direction. You can see now why they're called, these are the vocal folds here, you can see now why they're called folds. They're not really cords in the sense that they're rubber bands hanging in space. They're actually just infoldings of the airway. This is a close-up view. So that's the true vocal fold seen from the front, so that's right and left. And when they're apart, so they're sitting sort of like that, and when you're breathing they're apart and say E and they come together. These above are the false vocal cords. We can talk a bit about the false cords and their role in phonation, or rather the fact that they shouldn't be involved in phonation in a little bit. Pitch, when you twang a tuning fork, an A440 tuning fork, clearly the times are moving apart and together 440 times a second. So when you're singing, if you're a tenor and you're singing a top A, your vocal cords are moving apart and together 440 times each second. And if you're a soprano, the way the physics of it works is that if you go up an octave, so soprano top A, that's 880 vibrations per second. The Allegri Miserere top C is 1024 times a second. So the whole system, the ability of the vocal cords to move, has to be incredibly pliable and supple for the vocal cords to be able to move that rapidly. The vocal cord, there isn't a muscle that's kind of shaking 1,000 times a second. What happens is that the vocal cords start together. So a second ago you saw the vocal cords apart as the person was breathing. At the beginning of a phonation, at the beginning of producing sound, the vocal cords come together, and then the pressure from the lungs comes upwards and then pushes the vocal cords very slightly apart, so you get a little puff of air, and then the elastic recoil of the vocal cords causes them to snap shut again. And that moving apart and together, that's happening 400, 800, 1,000 times a second, whatever it is. And each puff of air causes the air next to it to vibrate a bit, and then the air next to it to vibrate a bit, and that propagation of the sound wave reaches your ear, vibrates the eardrum at 440, 880 hertz, whatever it is, and that's then translated by your brain into the auditory perception of sound, of the pitch. It is partly elasticity that causes the vocal cords to snap shut. It's also an effect called the Bernoulli effect, where if you pass air between two surfaces, there's a tendency for the pressure between those two surfaces to drop. So the pressure between the two goes down, which means that they tend to be drawn together. So it's a little bit of elastic recoil and a little bit of the Bernoulli effect as well. Happy so far? I should have said at the beginning, if you want to ask any questions, please do shout out, or if I'm not making anything clear. Everybody happy so far? Nothing too controversial yet? No? Okay. So this is a video of the vocal cord moving apart and together, just a sort of cartoon. And if we swing around the back of the larynx, you can see that the vocal cords are moving apart and together. They're not moving as a sort of block, if you like, with the air coming from underneath. And again, we're now in this kind of coronal section in this direction. Rather than the vocal cords moving apart and together kind of as a block, you can see that as the air comes between them from underneath, the lower part of the vocal folds moves apart a little, and then the upper part moves apart, and then the inferior, the lower part of the vocal folds comes together. So they're moving in this very kind of pliable, supple sort of a way. You'll notice also, and I'm going to talk about this more in just a second, but you'll notice also that there are multiple layers of the vocal cords, and it's those layers that allow the vocal cords to have the great degree of sort of suppleness and pliability that they need. So let's talk then about the sort of microscopic structure of the vocal folds. The layers are, in the dark yellow here is the surface layer known as the epithelium. The layer immediately underneath that is called the superficial lamina propria, or also known as Ranke's space, and then deep to that is this pink ligament. Now the importance of Ranke's space with its kind of jelly-like qualities that allows the surface of the vocal cord to move pliably over the underlying ligament. If Ranke's space is not there, and if the epithelium is stuck down onto the ligament, then you don't get smooth vibration at that particular point on the vocal cord. Yeah.
I had a student with Ranke's edema.
Right. We will come on to Ranke's edema in a little while.
Yeah.
Edema means swelling of. Ranke's edema, obviously swelling in Ranke's space, caused almost exclusively by smoking. But we'll talk about that in just a sec. So yes, that's sort of the opposite of what I'm talking about. So if you've got a very swollen Ranke's space, that's one thing. But if you've got no Ranke's space, then the epithelium is stuck onto the ligament underneath. The vocal cord doesn't vibrate, and when you perceive that as a rough sound. Then the pink is the vocal ligament, and the vocal muscle, the vocalis muscle, also known as thyroid. Well, the vocalis muscle is part of the thyroaretinoid muscle. So those are the sort of microscopic layers of the vocal folds. This is the sort of view we would get in clinic if you're examining a patient. we're looking with effectively, just silence that for a second. The way this is done is with an endoscope that goes through the nose and has a look over the back of the nose and down at the vocal folds. That's one way of doing it. Another way of doing it is with a rigid endoscope that sits on the tongue, and you look over the back of the tongue with a prism that looks down towards the vocal folds. Either way, you get this view of the vocal cords, and you can see here. You can see here that the vocal cords appear to be vibrating in sort of slow motion. In fact, they're vibrating 150 times a second, and the illusion of slow motion is given by a technique called stroboscopy. And in stroboscopy, you're flashing a stroboscopic light at the vocal cords with roughly the same frequency that they're vibrating at. So it gives this sort of illusion of slow motion. So as the vocal cords vibrate, you catch them at a different point on the vibratory cycle from one vibration to the next. So it looks as if they're moving in slow motion. That's a slightly long-winded way of explaining stroboscopy, but stroboscopy is really important for examining vocal cords when you're concerned that there might be scarring or tethering, and if you lose Rehnke's space, you lose the pliability of the vocal cords, and you wouldn't see that lovely supple impression and the pliability known as the mucosal wave. Mucosa is another word for the lining of the vocal cords, and the mucosal wave is that sort of belly dance motion that the vocal cords are doing. Happy with that so far? Yeah? All right, good. Let's talk a little bit about the vocal resonators. Now, if you were to take the larynx out of the body and just blow air through it, the vocal cords themselves produce a very uninteresting buzzing sound, and my larynx would sound not particularly different from any other larynx if you were to, any other male larynx, that is. The buzzing sound that is produced by the vocal cords consists of a fundamental frequency, one pitch that you hear, but also lots of overtones that you're not consciously hearing, that your brain is kind of integrating, and it says that that particular combination of overtones adds up to a buzzing sound. So you hear a fundamental frequency, and then you subconsciously hear lots of overtones as well. If you accentuate different ones of those overtones, that changes the quality and the colour of the voice. And we can consciously and subconsciously change the quality of the different overtones that are accentuated by changing the shape of our pharynx, by changing the shape of our oral cavity, the mouth, and by changing the shape of the back of our throat. So if you change the configuration of the tongue, if you change the configuration of the pharynx, it will bring out different overtones, and that changes the perceived sound. And the resonators consist of the pharynx, as I've said, oral cavity, the nasal cavity a little bit, not so much. The larynx itself has little kind of nooks and crannies where you can alter the shape to change the resonant frequencies. Sinuses, chest and skull, really not so much in terms of the resonating structures. And the harmonics, just to give you an example, if I sing a series of notes on different vowels, the pitch I'm singing at is the same across all 5 vowels. The only thing that has changed is the shape of my pharynx and shape of my oral cavity, and in each of those situations I'm accentuating different overtones, and that particular combination of overtones from one situation to the next makes it an R versus an air versus an E. So you'll know that an R is a fairly backed vowel, so with the tongue back. E, the tongue is quite far forward, and that changes the harmonics, changes the vowel you hear. And that changes also, incidentally, the characteristic qualities of different people's voices. We'll talk about that now with regards to classical singing. Classical singers have developed a particular trick of accentuating one harmonic known as the singer's formant. So this is a graph demonstrating a singer singing at one pitch, a sustained one pitch. Up here is the sort of loudness, and along here is the frequency. So you can see that there is a main peak at the fundamental frequency, but lots of other peaks at different frequencies for the overtones, for the harmonics. So that's the fundamental frequency and the overtones. You, as Western classical singers, have learned to accentuate this one particular resonant frequency at about 3 kilohertz that gives your voice its brightness. You can call it different things. You can call it brightness or laser or ping or ring or blade or whatever you want to give it the name, but it's that kind of laser-like quality that allows the voice to carry. And incidentally, it's that allows you to carry over the sound of a symphony orchestra, for example. Because in sheer decibel terms, you shouldn't be able to be heard, but actually the brightness of your voice, that particular singer's form of frequency, is what allows you to be heard. The way classical singers do that is by singing, relatively speaking, with a low larynx. In other words, you then have your. Again, I don't. In all of this, I wouldn't want you to get too tied up in the mechanics of it, because the more you think about, I'm going to tweak this muscle and pull that muscle and all the rest of it, you can drive yourself nuts doing that. But so just know about it, have it in your subconscious, and then park it when you actually go back to singing. But the advantage of having a relatively low larynx is that there's then quite a long distance between your vocal cords and the front of your mouth, and from the vocal cords to the front of your mouth, that's your vocal tract. And the deeper and longer the vocal tract is, the more opportunities there are to create those resonant frequencies, and it's by doing that that you demonstrate, that you accentuate the singer's form. Does that make sense? Yeah? Okay, good. Changing notes, if you have a rubber band and you twang it, the pitch that the rubber band sounds depends on the fatness of the rubber band. Clearly, a fat rubber band gives you a lower pitch, and it depends on the tension. So you stretch the rubber band, and the pitch of the rubber band goes up. Equally, in the larynx, men who have denser, fatter vocal folds have lower pitched voices compared to women, and it's in males in adolescence under the influence of testosterone. You get this surge of testosterone, and the larynx suddenly gets bigger, and the voice drops. Women's voices change as well, obviously, but more gradually and not to such a large extent. Any guesses as to what the larynx is for, fundamentally?
Stop choking.
Yeah, exactly. It's not fundamentally, I'm afraid, for singing Verdi and Wagner. It's largely about preventing stuff going down the wrong way. The larynx is a sphincter. I mean, first of all, it's a tube to allow air to get in and out of your lungs, but it's for protection of the airway. A sphincter is just a set of muscles that contracts tightly for whatever reason. This is a sagittal view, so this is a cut now in this direction, looking at the larynx. And you'll see, I'll show you a video in just a second, but you'll see that there's a series of actions that happen to prevent food and drink going down the wrong way. Coughing, thank you for whoever just coughed, is a motion in which you bring the vocal cords together, increase the subglottal pressure, increase the pressure underneath the vocal cords, and then forcibly abduct them, and that is very useful for expelling the foreign material from the lungs. We can talk a bit about throat clearing. I spend a lot of my time talking, not to singers necessarily, but to other people about the problems with throat clearing and how traumatic it can be to the larynx. We'll come on to that later if you like. Straining, so there are two situations typically in which you're straining. One is straining at the stool, and the second is straining in childbirth generally. And what you do in both of those situations is a thing called the Valsalva manoeuvre, in which you take a deep breath, close the vocal fold so that no air can get out, and then you increase the pressure from the lungs, but the pressure from the lungs can't get through the vocal cords because they're closed, so the pressure in here rises, which increases the pressure in your abdomen, which increases the pressure in your pelvis, and then you push the contents of your pelvis that way, whether it's stool or baby or whatever else. So that kind of action of straining and pushing downwards. Yeah, that's all I'm going to do there. This is really just to demonstrate that swallowing is a very complex, multi-stage process in which very precise timing applies to each step to prevent food and drink from going down the wrong way. The first bit of swallowing, the moving of the food bolus around inside your mouth, is under your sort of volitional control. By the time the bolus gets to the tonsils and beyond, you have no control over it at all. It becomes completely subconscious. So as this food bolus is going in the mouth, it's being chewed and moved around by the tongue. The soft palate is going to close. The whole larynx rises. The epiglottis flips over. the vocal cords close, the false cords close, and then the food goes down the esophagus at the back with this process called peristalsis that kind of sequentially squeezes the food bolus down. If any one of those bits of that swallowing process go wrong, if the tongue's not working, if the soft palate's not working, if one vocal cord is not working, if any of that is wrong, even in a relatively subtle way, then there's an opportunity for food and drink to go down into the lungs, which causes aspiration pneumonia. And it's something that we get very agitated about because a relatively small amount of material going into the lungs can cause significant problems. And that's why patients who've had a stroke, for example, who may lose the ability to swallow efficiently, quite frequently run into problems with chest infections because food and drink is going down the wrong way. And I spend quite a lot of my time treating patients with a paralysed vocal cord. So one of the things I just explained is that when swallowing, the vocal cords have to close tight shut. If one of the vocal cords is paralysed for whatever reason, then you can't get the vocal cords to close completely. That has its effects on the voice, certainly, but it also means that when swallowing, you're not completely closing the vocal cords, there's a gap between them, and there's an opportunity for food and drink to go down the wrong way. So having a vocal cord paralysis does leave you prone to chest infections. As I say, I spend quite a lot of my time treating patients with vocal cord paralysis. So you can feel some of this anatomy on yourselves. If you just grab your thumb and index finger and reach under your jawline, you'll feel kind of soft, squishy stuff just under the jaw. That's the muscles of the floor of mouth. And then reach down a bit further and you'll get to a bony structure. That's the hyoid bone, which sits at the very top of the larynx. If you then take your index finger and run your finger vertically, run your finger down in the midline, the next thing you'll feel in blokes is going to be the Adam's apple, the thyroid cartilage, here in yellow. Less easy to feel in women very often, but usually palpable. And then as you run your finger down a bit more, the next firm structure you'll reach is the cricoid cartilage. And the thyroid cartilage is shaped sort of like, if you're looking at me, it's shaped sort of like that. And the cricoid cartilage is actually a complete ring. And they're quite firm structures, quite firm cartilaginous structures. As you get older, they tend to calcify, so they turn into bone. So sometimes I do operations on the larynx in which I have to open up the thyroid cartilage to put implants in. In a younger person, I can cut the cartilage with a scalpel. It's relatively easy to do. In an older person, I quite often have to drill into the larynx to get the implant in, because it's turned into bone essentially. So yeah.
Does that change the sound of somebody's voice when that process happens?
Yes, it does. But to be honest, the situations in which I'm drilling into people's larynxes, their voices are really pretty poor to start with. So my aim is so if your question is whether opening up the larynx can itself cause a change to the quality of the voice, by and large, no, because by doing that, I'm not fundamentally affecting the either the muscles or the ligaments or the way the vocal cord is moving. But by putting an implant in from the outside, yes, that will fundamentally change. And actually, the reason I do these operations from the outside is in patients with vocal cord paralysis. And you can either in situations where one vocal cord isn't moving, you can either inject filler material into it through the mouth, or you can go in from the outside, drill a hole in the thyroid cartilage and put an implant in from the outside to push it across a bit. So it's in vocal cord paralysis primarily that I'm doing the external approach. But making a hole in the thyroid cartilage in itself doesn't necessarily change the quality of the voice. If I were to fracture the cartilage, and I've seen a number of laryngeal injuries over the years, rugby tackles that hit the neck, or lacrosse ball in one instance, when actually the whole structure, the whole cartilaginous structure of the larynx is bashed, and yeah, that can cause problems. But actually, just making a hole in the thyroid cartilage, not so much. So thyroid cartilage and cricoid cartilage, and the little dimple between the cricoid cartilage and the thyroid cartilage is the cricothyroid membrane. Cricoid, thyroid, cricothyroid membrane, and you'll be aware of this idea of the cricothyroid visor. So that in order to raise the pitch of the voice, you tilt the thyroid and the cricoid with respect to each other. And if this is the thyroid cartilage and this is the cricoid, as you raise the pitch, you go and you close the distance between the front inferior part of the thyroid cartilage and the upper part of the cricoid cartilage. So that's the cricothyroid visor. You can feel that on yourself. I mean, if you put your finger in that little dimple above the cricoid cartilage and below the thyroid cartilage and just do a pitch glide, first of all, you'll notice that your whole larynx rises, so try and ignore that for a minute, but as you do it, you'll feel that that gap between cricoid and thyroid closes. So that's the cricothyroid visor that some people talk about. The thyroid gland sits just above your sternum, just above the breastbone, in the lower part of your neck. In most people, you can't feel the thyroid gland. In some people, you can. It's much more common to be able to feel the thyroid gland in women than in men. Women do not infrequently run into issues with lumps and bumps in thyroid cartilages, in thyroid glands, I should say, and we'll talk about that again in just a second. Every muscle requires a nerve to tell that muscle to move. And in the larynx, there are 4 nerves. There's 2 on each side. The most important ones are the recurrent laryngeal nerves. Now, and the recurrent laryngeal nerve is responsible for moving the vocal cords apart, or telling muscles to move the vocal cords apart, and telling muscles to move the vocal cords together. The recurrent laryngeal nerve, this is it here, the recurrent laryngeal nerve starts in the brain, works its way actually all the way down into the chest, and then peels off from this nerve, from the vagus nerve, and then the recurrent laryngeal nerve scoops around here, and then ascends in the neck, adjacent to the trachea, adjacent to the windpipe, and then gets into the larynx that way. So it's quite a long path from brain to larynx, and there's quite a lot of opportunities, therefore, for the recurrent laryngeal nerve to be injured, whether that's surgical injury, whether that's a tumour growing into the nerve and compressing it, whether that's somebody who's having heart surgery. My concern always when I see a patient with a new vocal cord paralysis, and there's no obvious reason why they've got that vocal cord paralysis, so nobody's been operating near the nerve, for example. If they've got a new vocal cord paralysis, I worry that there's a cancer that's invading that nerve. Have they got a thyroid cancer? Because the thyroid gland is sitting right here. Have they got an esophageal cancer? The esophagus is right here. Have they got some sort of lung cancer? Because if you've got a lung tumour up in the apex of the left lung, that can impinge on the nerve as well. So the alarm bells ring when I see a patient with a new unilateral vocal cord paralysis, and we do a variety of scans and things to look for that. But injuries to the nerve are relatively rare. So the recurrent laryngeal nerve, as I say, is the one that brings the vocal cords together and moves it apart. And we were talking about thyroids and thyroid lumps and bumps a minute ago. Again, not uncommon for women to require surgery to their thyroids, occasionally men as well. When operating on the thyroid gland, which is right here, you're operating right next to the recurrent laryngeal nerve on each side. And surgeons are very alert to that fact. They are very cautious about avoiding injury to the recurrent laryngeal nerve, because if you do injure the recurrent laryngeal nerve, if you accidentally cut it, for example, that's really very bad news in terms of the voice. The other nerves, so that's the recurrent laryngeal nerve, 1 on each side. The other 2 nerves are the superior laryngeal nerves, which come from above. So this is the superior laryngeal nerve that peels off much earlier and goes directly to the larynx from the outside. And the superior laryngeal nerve is responsible for altering pitch. It goes to the cricothyroid muscle, and the cricothyroid muscle is the one that stretches the vocal cords. Now, if you're not a singer, then an injury to the superior laryngeal nerve probably wouldn't matter too much, because subtle, fine control of pitch of the voice wouldn't necessarily be your top priority. But for a singer, clearly, all of these nerves are of absolutely critical importance. The superior laryngeal nerves are more difficult to identify, from a surgical point of view, much more difficult to identify and to make sure that they're safe in the course of the operation. This is not to scare anybody off thyroid surgery. If you need to have your thyroid operated on, then so be it. But just if you ever do need to have thyroid surgery, make your surgeon aware that you're a singer, and if they only do 2 thyroid operations a year, then you need to find somebody else and find somebody who does 100 a year and really knows what they're about. Toby Spence had thyroid cancer, it's quite a while ago now. and he had a very extensive operation. I'm not divulging any secrets here because he was very public about it at the time, and he did not have any damage to any of these nerve structures, which is great. But it's worth remembering that when you have thyroid surgery, you make a socking great big incision in the neck, and you're also opening up the muscles. In order to get to the thyroid gland, you have to move muscles right out of the way to get at the thyroid gland. And those muscles are the strap muscles, and those are the anchoring muscles that allow you to lower the larynx, to raise the larynx, that gives you the flexibility in the voice. And Toby himself was very straightforward after he was recovering from his surgery. He said it was absolutely terrifying. He had no idea what was going to come out of his mouth. He booked himself to do a prom, I think, 3 months after his operation, said it was one of the most frightening things he ever did. Not because there was an intrinsic problem with the vocal cords, but just because the stability of the larynx had been really affected by having the strap muscles moved around so much. The giraffe has a very similar arrangement. You know, the nerve starts in the brain, goes right the way down into the chest, and then loops all the way back up to the larynx. It's, you know, the divine was not thinking very clearly on the day he designed, or she designed, this particular setup. So there's quite a long distance from the brain to the larynx in all animals. So we talked about vocal cord paralysis. This is a normal larynx, vocal cords coming together to produce sound and moving apart when the patient takes a breath. There we go. This is the image on the right is a patient with a vocal cord paralysis. Now you'll see that the right vocal cord here is moving fine. When they go he, you see this right vocal cord move fine. When they are, this left vocal cord is not moving at all. Do you get the impression of that? Now, there are two consequences of that. Firstly, they're never quite getting their vocal cords to come together properly, so you always have a slightly breathy voice, there's always air escaping. And secondly, as I said, when swallowing, there's a risk that particularly with liquids, they can go down the wrong way into the lungs and cause aspiration pneumonia, which is very problematic. And there are some, there's a variety of different ways of treating vocal cord paralysis, depending on the cause. We've got lots and lots of mucus-producing glands in the larynx. You will obsessively drink water, I'm sure, and not too much caffeine. Basically, the more water you drink and the less caffeine you drink, the thinner and more watery the mucus is. And in order for the vocal folds to vibrate smoothly, they do require moist surfaces. You will know that if you, on a hot day when you've had 3 cups of coffee, your mouth gets very dry and sticky, and equally the vocal folds get very dry and sticky. And if you know, the equivalent would be blowing a raspberry with your lips. If you want to blow a raspberry that's effective, you lick your lips first. Equally with the vocal folds, they need to be nicely lubricated. So 4 pints of water a day is pretty much what we would suggest. So we've talked about vocal folds, we've talked about the resonators. We'll talk a bit about the lungs now. Primarily, the lungs are not there to drive the Verdi and Wagner. They're there to get oxygen in and to get carbon dioxide out. They're a useful filter for the venous system, and they're an interface with the environment. You know, when you take a deep breath in, then the particulate matter, be it viruses, bacteria, pollen, whatever else, is meeting your body for the first time, sometimes in the nose, sometimes in the throat, but quite often in the lungs. So as an immunological function of the body meeting things for the first time, deciding whether these things are friend or foe, do they need to mount an immune response or what have you, the lungs are very important. And then last, and I'm afraid least importantly, the lungs are the bellows for the voice. So, you know, we've got this analogy of a musical instrument. The energy source is the violin bow or the lungs, the vibrating noise producer is the string or the vocal folds, and the resonating factors, the resonating chambers are the various different anatomical structures we've discussed. We're just going to talk a little bit about vocal pathology, if that's okay, some of the things that can go wrong. There are various different ways in which we can diagnose vocal pathology. The crux of it is that we need to have a look at the vocal cords, but there are other things we can do. So first of all, we can get patients to tell us subjectively what they think of their voices, and there are various questionnaires that we can get people to fill in. VHI stands for Voice Handicap Index. The Voice Handicap Index is useful I would say for non-singers, because it's quite prescriptive. It's not very descriptive of the specific problems that a person is having, but it's very repeatable. And what we like to do is to do a VHI for somebody before they've had an intervention, and then a VHI afterwards, and see that they've got better. We can listen to the patient, and there are grading scales where I will, and my speech therapy colleagues sitting in clinic, we will listen to a voice and then decide on different parameters what we think of the voice. GRABAS stands for grade, roughness, breathiness, asthenia and strain, and that's 5 different domains where we listen to a voice and decide how rough is it, how breathy is it, how asthenic is it, how sort of weak and feeble is it, and how strained is it, and then overall what do we think is the G, the grade of the voice. And then again, we're listening to a voice before and after and deciding roughly and hoping that you get an improvement from one situation to the next. The laryngeal examination, the laryngostroboscopy, is the critical bit of the examination. Just going back to VHI for a minute. I mean, if you've ever been seen in a voice clinic, you may have filled in a VHI, but the truth is that actually the measures that the VHI takes are pretty crude, and the problems that singers are likely to run into with their voices are much more subtle than that. I'm having a problem with my passaggio is not going to be picked up by the VHI, or my falsetto only works on closed valves rather than open valves. Again, is not going to be picked up by the VHI, which is why it's much less useful for singers. Yeah.
Could you just explain what grade is?
Great. Yeah. So grade is the sort of overall grading of the voice. So I'll explain that a bit more thoroughly then. So I'll come back to G in a minute. RBAS, for each of those, I will decide whether the voice is normal, 0, mildly affected, 1, moderately affected, 2, or severely affected, 3. 0, 1, 2, or 3 for R, and the same for B, A, and S. Having decided on the R, B, A, and S, we then kind of come to a conclusion as to the overall grade of how bad we think the voice is generally. And there's a lot of these kind of medical things have just come about, or almost the back of a flag packet thing. This GRABAS came about, there's a guy called Hirano who came up with this in the 1970s, and actually his original description is just one paragraph at the end of a chapter. He thought we probably ought to have something, so he just wrote this stuff down. And the problem is that because he was the first person to think to do that in an objective way, everybody just stuck with it, and it's probably not the best measure we've got, but it is the most widely used one. So GRBAS, so stroboscopy laryngostroboscopy is the key thing for examining the larynx, and if you ever needed to have your voice evaluated, then you need to ensure that you see somebody who's got the right kit, and the stroboscopy stuff is absolutely paramount in that. There are various different kind of specialist tests that you can do using computers to analyse voice recordings. Again, for singers, the subtleties of the problems you would run into with your voices would not be picked up by these sorts of recordings. They're fairly crude, and actually they don't really add very much. I mean, the most important thing, I think, for me as a clinician is to ask the patient, are things better? A, what's the problem? And B, having treated you, are things better? What the computer tells us in terms of the numbers before and the numbers afterwards is of much less importance, I think. Glottography is just a way of measuring how efficiently the vocal cords are coming together, but again, not particularly in widespread use. So Manuel Garcia was credited with inventing the first laryngoscope. He's got a mirror. It's like a dental mirror. He's got a dental mirror in the back of his throat. He's looking into this mirror, which is looking into the mirror in the back of his throat. The only way he can get light is with an oil lamp, and this is a mirror as well. So he's got an oil lamp shining light into a mirror here, shining light into a mirror here, and then into the back of his throat. It must have been quite uncomfortable and really convoluted, and with the quality of oil lamps back in 1841, I suspect he didn't see an awful lot. But he alleges that he could see his own vocal cords. We've moved on quite a long way now. This is me looking a lot younger actually at this stage. This is my friend Nigel examining me. The majority of the time these days, if you are going to have your larynx examined, it will be done with a flexible endoscope that goes through the nose, which is not remotely as bad as it sounds. It sounds horrible, but if you've had it done, you'll know it's not too bad. And often we'll put some local anaesthetic spray in beforehand. So you go through the nose, over the back of the nose, and then looking vertically downwards now towards the vocal cords. So that's the right, that's the left, back and front. This is my epiglottis in the foreground, and that's me phonating. The other way of doing it, and we were doing this an awful lot more until about 10 or 15 years ago, is using 70-degree rigid endoscopy, in which there's a metal rod that sits on the tongue, and it's got a prism at the very end of it that looks over the back of the tongue and downwards. In order to get the tongue out of the way, the examining person has to hold onto the tongue and pull it outwards. The only noise you can produce when you've got a rigid bar on your tongue is so it's not a very sort of dynamic way of looking at the larynx. When you've got a flexible endoscope in your nose, you'd be surprised, but you can actually do pitch glides, you can do different vowels, you can sing a phrase of a song if you want, and it's not nearly as bad as it sounds. So the dynamic information you get from doing a flexible endoscopy, I think, is very much more valuable than doing a rigid endoscopy. All right? Talking about voice disorders for a minute and how we classify them. Julian McGlashan, who's a laryngologist in Nottingham, came up with 4 broad sort of categories of voice problems. Inflammatory things, neoplastic just means new growth and structural things, so that would include lumps and bumps, muscle tension imbalance, and neuromuscular. It's worth remembering that a problem in one of these areas can cause problems in another. So if you have, say, a polyp on one of your vocal cords, it is likely that you're going to run into muscular problems simply because you're sort of holding the larynx in a certain way so as to try to actually get the voice to work as efficiently as it can. We can remove polyps surgically, but you may still be left with muscle tension imbalance problems. So having had a polyp removed, it's often necessary to have some vocal coaching or some vocal therapy to unpick some of the muscular tension problems that can creep in. Equally, problems in the way you're holding the larynx can cause structural lumps and bumps, and the classic example of that is vocal cord nodules. And nodules arise when you're using the voice in a very energetic way and you're bashing the vocal cords together with a large degree of force. They often arise, in my experience, in 12-year-old boys and 20-year-old women for whatever reason. But I just think 12-year-old boys running around on a football pitch, and incidentally, I've seen lots of choristers over the years who have to make some fairly difficult decisions about whether the football and cricket are going to take precedence over the singing in chapel 7 times a week. Or how to balance those things out. So vocal cord nodules happen when you bring the vocal cords together with a lot of energy, and at the point where the vocal cords vibrate with maximum intensity, that's the point at which you get these little calluses, these little thickenings on the vocal cords. And the primary way of treating vocal cord nodules is actually with vocal therapy, with trying to get people to use their voices differently so that they're not bringing the vocal cords together with so much force. And they all connect to each other in different ways. So we can talk about some of these lumps and bumps. Ranke's edema. Let's talk a little bit about Ranke's edema then. Ranke's edema is swelling of the Ranke space, which again is that jelly-like superficial lamina propria space just under the epithelium. Ranke's edema happens exclusively, I would say, in smokers. You can get vocal cord edema in other situations, but for it to be Ranke's edema, it really is in smokers.
I think she might be holding back on the smoking info.
Okay.
Yeah.
I mean, if you can have vocal cord edema, I wouldn't call it Ranke's edema if it's not really caused by smoking. So you can have vocal cord edema in other situations, but Ranke's really quite specifically refers to smoking. Very, very occasionally, if you have an underactive thyroid, that can lead to vocal cord edema, but that's really extremely rare. And my experience is that people will hang on to the fact that, well, it might be my thyroid, doctor. No, it's the 20 a day that's the issue. It's not going to be a mildly underactive thyroid that's causing the problems. So vocal cord nodules are bilateral. They happen on both vocal cords, and they happen, as I say, as a result of prolonged and excessive voice usage. They happen over a period of time. They would arise over the space of months and years rather than as an immediate thing. A vocal polyp, on the other hand, will happen as a sudden, single, phonotraumatic event, if you like. So a single big yell, or one particular concert, or one big cough, or whatever else, and the quality of the voice will suddenly change, and we'll talk about that in just a minute. Rankin's edema we've talked about. A cyst is a pocket of fluid within the vocal fold, and again can arise as a result of trauma. Inflammatory things, well, I don't very often see viral or bacterial laryngitis because, you know, by the time somebody gets to me, it's usually resolved of its own accord. I do see quite a lot of fungal laryngitis. I see quite a lot of thrush in the larynx. I see that because it's quite common in patients who are on steroid inhalers for asthma. So if you're on a steroid inhaler, you'll know that getting candida, getting thrush in the mouth can happen, and equally that can happen in the larynx as well. It's relatively straightforward to treat. There are lots of antifungal medications that can be provided, and trying to avoid candida largely revolves around making sure that you need to be on the inhaler in the first place. If you don't need to be on a steroid inhaler, then stop it. And secondly, gargling and rinsing your mouth out after you've used your inhaler, because when you take an inhaler, most of it gets into your lungs, but a certain amount of it lines your throat and vocal cords and can set you up with fungal laryngitis. We can talk a little bit about reflux and allergies, but we could be here for months talking about reflux if we wanted to. And I'll talk about allergies a little bit as well. I've got a particular interest in vocal cord paralysis and nerve palsy. We were talking about the recurrent laryngeal nerve and injuries to the recurrent laryngeal nerve, and that causes a vocal cord paralysis, and there are various different ways I can treat that. Spasmodic dysphonia is a neurological condition in which you get spasms of the vocal cords that cause a very characteristic and very unusual sounding voice in running speech. And it sounds it's really rare. It's about 1 in 100,000 people. And in spasmodic dysphonia, the patient's voice sounds very staccato. So it kind of sounds strangled and tight and strained. It's a really, really odd condition. It only happens in running speech. So quite often these patients can sing absolutely normally, can put on voices, can sing in falsetto absolutely fine, but in running speech they have this spasmodic quality.
I actually had a teacher with it.
Oh, did you?
John
Okay.
Wakefield.
Okay.
Yeah.
And what treatment do they have?
Well, I think he had lots of therapies, but I mean, his speaking voice is terrible, but he could still demonstrate.
Yes.
His
How old was he?
voice is fine. He died a few years ago.
Okay.
So, yeah.
Yeah. I mean,
It's extraordinary because my first lesson I was like, goodness
what
me,
is that? Yeah.
how did he ever sing? And he did sing.
But does sing, exactly.
Yeah.
It kind of demonstrates the point, yeah.
Because I never saw him around.
Yeah.
I knew him because he was one of the other teachers, but I was
Right.
like, how is that a singing teacher?
Exactly.
Because I never heard him sing. I only heard him speak.
Yeah.
What's his name? John
John Wakefield.
Wakefield.
Tenor.
Okay.
Had a lovely tenor voice, beautiful.
Gosh.
It's in its heyday.
Oh, there you go. Well, and the treatment for the last 30 years or so has revolved around Botox injections. So I do
Yeah.
Botox injections into the vocal cords. I'm glad I never had to see him as a patient because I would have had an interesting conundrum in my mind, because the way Botox works is by poisoning the muscle, botulinum toxin, and it weakens the muscles of the larynx. So by injecting him with Botox, I probably would have smoothed out his speaking voice and got much better fluency, but that would definitely have had a weakening effect on his singing voice. So it's the kind of conundrum I'm quite glad not to have had to face. There you go. So anyway, spasmodic dysphonia, really rare, really interesting. So if you ever see a patient, if you ever come across somebody in that situation who's got a very odd sort of staccato voice, they can sound kind of nervous or hesitant or whatever, and it just sounds really odd, but you now know that it's spasmodic dysphonia. And actually ENT surgeons and speech language therapists, it can take ages for the diagnosis to be reached because it's so rare that nobody's ever heard it. And the average time from the onset of the symptoms to being diagnosed with it is 4 years. So patients will go to hypnotherapists and acupuncturists and psychotherapists and goodness knows what, because everybody thinks it's psychogenic. And then finally they'll see a speech therapist or an ENT surgeon who knows what this is, and the pendulum will drop, and then they'll start having Botox injections. Sorry, you had your hand up.
Later.
Okay, later. Right, fine. And then behavioural things, so lifestyle and vocal hygiene. Vocal hygiene just refers to the way in which you look after your voice. Muscle tension dysphonia is a bit of a catch-all phrase that refers to muscle tension imbalances that cause problems with the voice. Dysphonia just means a problem with the voice. So in singers, the most common really is the muscle tension problems. When I see a singer in clinic, most of the time there isn't a sort of structural, visible, definable thing on either of the vocal cords. Usually it's to do with muscle tension and imbalance, and in that case either speech therapy or vocal coaching or both is the way forward. I do quite frequently see lumps and bumps on vocal cords, and occasionally those need removing surgically. And inflammatory things common as well, reasonably common. So when I've seen somebody in the voice clinic, quite often the outcome is actually your larynx looks fine, it's fine to go ahead with the show tomorrow night or whatever else it is, and we end up doing nothing. Singing, coaching and teaching, laryngeal manipulation and massage, I mean you'll be aware of the sort of physio eds and all of those characters who are very busy and do fantastic work. I think it's fair to say that there are different styles of vocal massage. There are some people who are really quite intense and people will come out quite uncomfortable and yet say their voice works with a freedom they've never known before. There are other people who will say, who will have a much sort of softer approach to it. Speech therapy is helpful in situations where the speaking, for my mind, speech therapy is helpful in those situations where the speaking voice is part of the underlying problem that has led to the vocal difficulties in the first place. And we'll come back to speech therapy in just a sec. By medical treatment, I mean sort of non-surgical things, so whether that's antibiotics or antifungals, as I just described, steroids I do sometimes prescribe as well, long-term anti-reflux treatment or long-term other medications as well. And then occasionally we're talking about surgery for singers. So one of the things that I do when I'm in clinic is to see a patient and then try to decide which of this kind of multiplicity of things is going to be best for the patient. Because what I don't want to do is to say, right, you need 8 different things to go away, because that just completely bamboozles people. So I think having some very clear, definable outcomes that can be focused on, I think is really helpful. If it's obvious that an operation is going to be needed, then we often just sort of cut straight to the chase. Surgery in singers, poor old Julie Andrews. I mean, I would say that surgery in singers is to be avoided unless absolutely necessary. I don't know Julie Andrews, but you know of the sort of Julie Andrews story. I think she had an operation that was not done judiciously, shall we say, and she has ended up in that situation of vocal cord scar. My understanding is that in doing the operation, rather than just removing the tiny lesion or lesions that were present, the surgeon then actually ended up going quite deep into the vocal cord, which has set up scarring. And I've seen this a few times over the years, and it's trying to undo laryngeal scarring is very, very, very difficult. And Julie Andrews ended up throwing millions of dollars at research projects in Boston trying to address exactly this, but I don't think she ever really got back to where she wanted to be. I'm aware that my clock says we've got 5 minutes, so I'm just going to show you a few bits of pathology, if that's okay. If you want to hide behind your couches at this stage, you're very welcome to. Singers are really, really very paranoid about vocal fold nodules for reasons I don't know. For reasons I do understand, but I think they have historically been given a bad press, shall we say. And I think saying to a singer that they've got vocal fold nodules is not the end of the world. It's not the end of a career. It's a reflection of a particular way that person is using their voice, and they will need to modify how they're using their voice in order for the vocal fold nodules to go away. I think they got a bad press because in the past people would have recommended hugely long periods of voice rest. In the past, surgery was perhaps not as refined as we would do it now, and did lead to vocal fold scarring. So for whatever reason, nodules are a subject of fear to many singers. So you'll be aware that the vocal folds should look absolutely dead straight, and you can see in this lady's case, I'll just play the video, you'll be aware that there's a very subtle degree of swelling in the middle part of each vocal fold, and as she's phonating, it's really just the nodules themselves that are coming together to produce sound. Oops. And hence, when she's producing sound, there is a little bit of a gap at the back, and there's a little bit of a gap at the front, a gap at the back and a gap at the front. So she's got a breathy quality. She has difficulty getting into her upper registers, because in order to produce your upper registers, whether it's the male falsetto or the female head voice, the vocal folds have to be absolutely dead straight, because they're stretched really thin when you're going into your upper registers, and that you need an absolutely dead straight edge. And if you've got a swelling on either side, then that prevents that proper closure, and people will run into problems with their upper registers. The primary treatment for vocal fold nodules is voice therapy and vocal coaching. She did very well with applying herself to the vocal therapy and modifying how she was doing things. In the end, she did not make the improvements that she needed to make, so she's one of a small group of patients who needed vocal cord surgery to address her nodules. So this next photo is of her asleep. So this is a photo taken under general anaesthetic. This bit of plastic between the vocal cords is the breathing tube, the endotracheal tube that's keeping her breathing. Because she's now lying on her back with her mouth open, so we're looking from above, from the mouth from above. So that's now the front and that's the back. That's left and that's right. And you can see the vocal fold nodules really quite clearly there. This is the bit probably to hide behind the couches. This is just a short video of one of the nodules being removed. The key thing here is, so firstly, to say that I've got the instruments I'm using are about 1 foot long or so, and I'm reaching in through a tube in the patient's mouth, and I'm looking down a microscope, and I'm grabbing the nodule, and then in my other hand, so that's in my left hand, in my right hand I've got a little pair of scissors on the end of a stick, and that is using the scissors to remove the nodule and give, the idea is to give the vocal fold a completely dead straight edge, and that's sort of what's achieved at the end of doing that. You could be a radiologist, they don't see much and those actually, in the grand scheme of things, those are relatively big. Those are probably 3 or 4 millimetres in size, but there are situations where we have tiny lesions that measure less than 1 millimetre or so. The principle is just the same. Grabbing it, pulling it medially, pulling it inwards just a tiny bit, not pulling it too hard, because if you do that, then you're going to end up with a big sort of crater in the vocal cord, a big cookie bite. And again, it's worth remembering that these are only about 1.5–2 centimetres long, so it's quite, so operating down the microscope. Sorry. You need to sort of rest the instruments on the laryngoscope and then kind of fulcrum. It's fine, it's fiddly, but it's entirely doable. This again, and the other thing I would say is that the amount of blood there looks like an absolute torrent, doesn't it? Again, these things are very, very tiny. And what I'm going to do in just a minute on this video is just to put a little gauze down there with a bit of adrenaline on it, and the adrenaline will cause the vessels to tighten up, and then the bleeding will stop, and then I'll go ahead and do the other side in just a minute. There we go. So that's removed. Yeah. So this is my adrenaline patty going down.
Can I ask?
Yeah. Go ahead.
Obviously, we can only be so precise when we do stuff like this. So there's bound to be some residual imperfection after the cut. Is that going to go away with rehabilitation?
It depends.
Is the scarring going to kind of...
So firstly, the idea is that there should be no scarring.
Okay.
So you would hope that by the time somebody comes back to clinic for their post-operative endoscope, it should all look as if nothing has ever happened, so all that suppleness and pliability has come back. Secondly, you're absolutely right about there being little kind of imperfections. In this case, I agree that there was a little bit of residual imperfection, particularly at the back part of that right vocal cord. I would probably just trim that a little bit further, because I like to get the edge of the vocal cord looking absolutely dead straight.
Okay.
Yeah.
Thank you.
All right. And that's it at the end of her operation. And we can talk about voice rest and stuff after surgery. Basically, the patient needs to rest their voice for sufficiently long for those surface layers to heal over a bit, but not for so long that the muscles atrophy and become weakened. And secondly, when you're using the vocal cords post-operatively, I think it's important to start relatively early so that pliability and suppleness and the collagen is laid down in the right sort of way. And this is her post-operatively. nice straight vocal cords. And importantly, in a minute when we get the stroboscopy going, you'll see that the mucosal wave, that the pliability has come back nicely as well. There you go, she's got much better closure. So this is just another example. So this is a soprano who had a sore throat and sang. Not, it could have happened in any circumstances, and clearly this is the left vocal cord is normal. The right vocal cord has got a bruise in it. It's got a vocal cord hemorrhage. Difficult situation to know how to manage, actually. I mean, firstly, this isn't painful. The only problem she had noticed was a bit of sort of cloudiness in the voice, actually, and a bit of difficulty with her upper register. So in spite of how dramatic this looks, her voice wasn't too bad at the time. There are several issues with this, really. First of all, when this sort of bleed has happened, we want the bleed to resolve, and we want it to resolve in such a way that it doesn't leave behind any residual scarring. Now, in this situation, I would therefore suggest that they rest their voice, allow the bruise to settle down, allow the hemorrhage to settle down, and then come back a week or two later, and we have a look and see how things are going. Sometimes this sort of bleed happens because there's a prominent blood vessel that has popped, that has burst. You can see a couple of little small blood vessels actually on the left side. Lots of people have little blood vessels that mean absolutely nothing, but if we can't really see because of the huge bruise, but if this patient, for example, had a big prominent blood vessel, it may be that was prone to popping and prone to causing bleeding. And in the longer term, if they had recurrent bleeds, then you might want to go in there and use a laser to just gently zap those vessels and ensure that doesn't happen again. So this is going to require a bit of time off, because you're going to have time for the bruise to recover, time to see them again and see whether there are any underlying vessels that are going to need treating. So those are relatively subtle things. These now are not singers. This is a vocal cord granuloma. Now, you're getting quite good at identifying abnormalities and aberrations, but this one's pretty obvious, isn't it? So this looks like a socking great big bit of fruit sitting in this guy's larynx. Again, not painful. He hasn't got a feeling of a lump in his throat at all. He's got a little bit of soreness on the left side of his throat. So this granuloma, a granuloma just means an inflamed area. This granuloma is arising from the back part of the vocal cord. And it happened in this chap because he had had an operation on his ankle when he was on holiday in Cornwall, and in the course of having the operation on his ankle, the anaesthetist intubated and put a tube in, and just as he put the tube in, very gently skirted one of the cartilages and took the surface lining, the mucosa, off the cartilage, and that left exposed cartilage, and when you get exposed cartilage, you are prone to these developments of granulomas. Now, the problem is that if the response as a surgeon to seeing an abnormal lump is to go, cut it out. And the difficulty is that if you see one of these and you cut it out, then you expose even more cartilage, so the granuloma comes back even bigger, and then somebody else cuts it out and it gets even bigger. So the truth of it is that the best way of managing granulomas is to relax, don't worry that it's cancer, because this is not going to be cancer, and leave it well alone. And most of the time, granulomas will settle down of their own accord.
So they reabsorb?
They settle down, yeah. In this case, it's so huge it didn't, and I had to do some other things. But small to medium-sized ones, I will do nothing with. I'll leave it alone. What you do want to do is to stop any irritative voice and throat habits. So throat clearing, yelling, any reflux that's there needs to be treated as well. But granulomas, on the whole, I would leave well alone.
So how can you tell the difference between a granuloma and nodules?
So a granuloma, firstly, is always on one side only. Nodules are always on both sides. And a granuloma happens at one specific point at the back of the larynx. It's so huge you can't really see where it comes from. But if it were on the right side, it would arise from here, always from the vocal process of the arytenoid cartilage. Nodules are always here, and then much, much more subtle than that. Yeah.
What is the visible difference between that and a cancerous?
So that's a really good question. In fact, I'll show you something else in a minute. I'll show you a cancer in a minute. So this is a vocal cord polyp. This is a guy who had a bit of a yellow football match. You've seen some fairly subtle things. That, again, not painful, not causing him any problems other than a slightly husky voice. And this is not one of... Sometimes small lesions can resolve of their own accord. usually within about 3 or 4 months if they're going to do so. This is not going to resolve of its own accord. But the surgeons will be fighting each other off to treat this, to operate on this, because it's going to be so satisfying. You're going to grab the thing, you're going to grab the thing, snip it off. So you'd have to LB a registrar out of the way to get to do this. And that will result. You can see also, actually interestingly, he has got a bit of hemorrhage in that left vocal cord as well, which is not surprising given that that's a slightly hemorrhagic looking thing in the first place. Yeah.
So when you said it would normally recover by itself over several months,
Yeah, so it's a
what should
small.
that person do? Should they not be singing, or should they?
Well, it depends very much on the situation.
Yeah.
The usual situation, I would say, is that a patient with, I mean, this is by most standards big. So a patient with a small polyp, a singer with a small polyp will usually identify that there's a problem at a particular point, think, this isn't quite right, carry on singing for 3, 4, 5, 6 weeks, and then come and see me. And then, actually, by the time I've seen them, they are several weeks, if not months, into the whole process. And if it were going to have resolved of its own accord, it probably would have done by then. So usually the situation is that it's not going to. But if I see them relatively acutely, I would say actually probably conserving the voice as much as possible, and then coming back in, 3, 4, 5 weeks to have another look and hope that it has resolved of its own accord.
Actually, at college, I don't mind saying, I had a polyp, and I went to see a guy called Robert House.
Oh yeah, Tom House. Yeah.
And I said, should I stop singing? And he just said, no, you just need to start doing it properly.
That's really harsh. That's really harsh.
But it turns out he was right, because he then sent me to see his sister, Dinah.
Yeah.
Is that his sister?
Dinah, yeah.
And within 6 months, she had retrained my voice and it vanished.
Yeah.
And actually, it's the best thing that could have happened to me at that time.
Yeah.
So I think the stuff I learned from that experience and with her has still been the basis of how I sing.
Yeah. No, it's interesting. I mean, operating on, there are several things. That's definitely true. When I operate on singers, quite often they will come back post-operatively and say, although I thought it was March 2023 all this started, with hindsight, I think there were probably problems for a while before that, and there was something sort of brewing. There's something else that just popped into my head about Tom and Dinah. No, I know what I was going to say. It's a bit harsh to say it's your own fault, it's bad technique. Because I see singers with absolutely immaculate technique. I see teachers of teachers who run into problems with vocal cord pathology. So I think this is another problem with the sort of self-beating up that singers do. If they run into problems, it's all my fault, what have I done wrong, how could I have... it happens all the time to all sorts of people. So.
It was just one phrase, and Tom did have a particular way with the words.
So there we go. Looking after your voice, this is all going to be fairly straightforward and obvious to you, and you'll all be doing all of this anyway. The totality of somebody's vocal loading is something we talk about quite a lot, and by that I mean, you can have the most immaculate singing technique you like as a chorister in your chapel experience. But if you are also a football playing, cricket playing boy with 3 older brothers in a noisy household, well, it's that's the problem. It's not actually the singing. So the total vocal loading, the total amount you're using your voice and the way of using your voice is the main issue. I'm going to skip over some of these because I'm conscious that I'm running out of time, but asthma, do you need to be on the inhaler? If you do, fine, but making sure that you gargle and make sure that you do that properly, and consider laryngeal candida if you're having voice problems. Reflux, I might just skip over reflux a little bit because it's such a sort of thorny thing, but we can talk about it in the Q&A if you like. Hay fever, we'll be running into hay fever season in a few weeks, I guess, months maybe. Being optimistic. Nasal sprays are my kind of primary way of managing hay fever. I don't particularly like antihistamine tablets because they do have a habit of drying you out. The nasal sprays get into your nose, stay in your nose, and almost none of it gets into your system, and that treats the nasal and the eye symptoms very well. What do you do if you have a sore throat? Well, there isn't a sort of single magic answer to all of this. I think what I would say is that if the quality of your voice is normal, then that implies that even though your throat is sore, it implies that the vocal cords themselves are not necessarily inflamed or swollen or angry looking. But if you are actually hoarse or if your range is affected, then that implies that the vocal cords are affected, so you probably need to avoid singing. If your throat is... an example of that would be... somebody I saw a few years ago who had raging tonsillitis, horrible big golf ball tonsils with white pus on them, but actually his voice was okay, and he did a big gig and he was absolutely fine, although he felt grotty. Pain after singing is seldom a sinister feature. You know, if your throat starts to ache 30, 40 minutes into rehearsing or practicing, that's usually a kind of muscular cramping effect than anything else. What's so bad about smoking? So here's the Ranke's edema. This person's got such swollen vocal cords that as they breathe in and out, they're kind of flopping in and out of the airway. And he had an absolutely appalling voice. We were talking about cancer a second ago, so this is a patient with cancer. Now, let me just wind it back a few frames. So this big craggy mass all around the left side of the larynx is the cancer. That's his, on that left side, that is his normal right vocal cord, and that little slit is the airway he's breathing through. So he's breathing through effectively a straw. So that noise is called stridor, and stridor is the kind of noise that we as ENT surgeons walk towards fairly briskly because he's going to run into problems with his airway quite soon. So he ended up having a tracheostomy, and then he had a laryngectomy, so he had his entire larynx removed to treat that cancer, because that's not going to be manageable with anything other than a big operation. So you can see it's a big horrible. So that's somewhat different from the granuloma in answer to that question. There you go. So I'll leave you with a few top tips. If you do need to be seen by an ENT surgeon, you must insist on stroboscopy. It's quite useful actually to have videos of your larynx. If you go and see somebody and your larynx is healthy, take a video of it actually, because then if you do need to see somebody in Hamburg or New York or wherever you are next, you can compare what it looked like previously. Hey, I'll take some questions. Yeah.
Yes, you mentioned asthma.
Yeah.
How about the associated condition COPD? I suppose they're linked in a certain
COPD and asthma. So COPD is almost always caused by smoking.
Okay.
It's treated in sort of similar ways with inhalers and sometimes nebulizers and various other things. I've never encountered a singer who has COPD because actually by the time your respiratory, well, firstly because very few singers smoke anyway, and secondly by the time your respiratory function got that bad, I think you'd have such poor breath control and such poor ability to control the voice that you'd be thinking about other things at that stage.
I was thinking, is it more likely to have, with COPD, is the mucus coming from the lungs? Can you explain a bit more about, medically, what is it that comes out of your lungs that causes mucus and that kind of thing?
Well, so we're all producing mucus all the time. In COPD, in smoking in general, smoking kills off the cells, the cilia cells. Cilia are little hairs, so the cilia cells waft mucus around. And in smokers, it kills off those cilia, so the ability to gently and rhythmically waft the mucus out is reduced, so they just can't clear mucus, and that's why you get this horrible hacking cough for smokers, because the mucus that should be just gently making its way up and you swallow it, and gently making its way up and you swallow it, that's removed, so it sits there in a sump, and they have this horrible kind of wet cough. So that's the primary thing.
But mucus is obviously very, just generally, some degrees of it, but even with people who would never smoke, you would have mucus. And I suppose it's a healthy level of mucus, isn't that? Is that a necessary amount of it? Or?
Yeah, it's not even necessarily so much, I don't think, about the amount of mucus, because broadly speaking we're all producing much the same. I think it's about the quality of it and the sort of the thickness and the stickiness of it.
Right.
So yeah, again, that's where the hydration comes in.
Okay, thank you.
Yeah.
Just thinking about voice clearing, throat clearing.
Yeah.
Why that's particularly a no-no.
Yeah. So throat clearing involves you forcibly bashing the vocal cords together. So first of all, it's traumatic to the vocal cords. Second of all, it very rarely actually clears very much in the way of mucus. And third of all, in irritating the larynx, it makes you want to clear your throat even more. So it becomes a vicious cycle. It's a bit like the itch-scratch cycle. The more you scratch a bit of skin, the itchier it becomes, and you want to go back and keep having a go at it. And the solution is actually to consciously stop yourself from throat clearing. If you do have mucus on the vocal cords that you need to clear at any particular moment, a better way of doing it is with a gentle huff, and that will clear mucus. But repeated throat clearing becomes habitual and doesn't really achieve what you think it's achieving. It's just perpetuating this cycle. Yeah. Sorry, you had a question?
I have a little bit of a weirdly specific question. I'm a singer here at the opera studio. Have you had any experience with singers with Bell's palsy?
Bell's palsy?
Yes. I had Bell's palsy 4 years ago.
Yep.
And it was so severe that it paralyzed my vocal cord as well. And I'm just curious if you've experienced that.
So Bell's palsy is, for everybody else, is a condition in which you get a paralysis of one side of the face. And it's not really known why it happens. We tend to do various tests at the time to check whether there isn't anything pressing on the nerve, or viral things or autoimmune things. And if you do a whole bunch of tests and they all turn out normal, then you shrug your shoulders and go, oh, it's a Bell's palsy. Bell's palsy, by definition, is only a facial palsy. So if you've had a facial palsy and a vocal cord paralysis, then I wouldn't have called it a Bell's palsy. I'd have called it I don't know, I haven't really thought of the name. Costello's palsy. There you go. I'll take it. But if they, so you had your larynx examined at the time, did you?
Yeah. So I was first diagnosed with the Bell's palsy, and then I was struggling with my singing
Right.
for several months afterwards. I'm a coloratura, and I'm struggling with my higher notes.
Yeah.
So then I went in to see an otolaryngologist, and then he said he did a scope, and then he said, "Oh, one of your cords is partially paralyzed as well." And he said that he thought it was from the palsy, but now I'm like,
Yeah.
what happened?
So I think the other thing that's worth saying is that everybody's larynxes are a little bit asymmetric, and a subtle degree of asymmetry of movement between the two sides might not have been a pathological thing, and actually, although you saw it at that time, it might be that it had been there for a lot longer. So that's not a combination I've encountered in the past. Interesting. Sorry, you had a question next, yeah.
I was just wondering what the effects, like what happens in the voice when people have like vocal fry.
Yeah, so in vocal fry, there's a brilliant YouTube video I should share actually, it's very entertaining. Vocal fry is that vocal creak. I can't really do it at the moment because I'm too warmed up, but when you're, it's when you detension the vocal cords, and rather than vibrating in a nice, smooth way, they're vibrating in a slightly chaotic way. As I say, I can't do it at the moment, but you know what I mean.
Yeah.
Yeah.
But like, what can it have negative?
So in and of itself, no. I mean, it's not going to cause trauma to the vocal cords. It's not a particularly useful thing to do, and if you do it in the long term, it could lead to kind of muscle tension imbalances that might become a little bit difficult to unpick, but not fundamentally damaging. No.
Cool, thank you.
I was just going to say about reflux, because you said it's a bigger thornier issue. Have you published anything about it? Is there somewhere we can
I
look?
personally know. So the thing about reflux is that about 25 years ago, a chap called James Kaufman, who is now a lady called Jamie Kaufman, published some research on reflux that had previously not even been considered in throat problems. And all of a sudden, PPI, so omeprazole, lansoprazole, pantoprazole, all of that were being prescribed like Smarties. Everybody had PPIs at that time for a little bit of a tickle in the throat, to a slightly husky voice, to anything. And we've, over the last 10 years, I would say, we've really tried to wean ourselves off that knee-jerk PPI thing, because PPIs can be problematic in the first place, and because actually there is quite a large debate about to what extent reflux affects voices anyway. And part of the problem is that making a diagnosis of reflux is not something you can do just by looking at somebody's larynx. you can sometimes kind of, if somebody's got raging reflux and the vocal cords are pink and everything's really inflamed and they say they've got horrible heartburn and a taste of acid in the back of their throat 10 times a day, okay, that's going to be reflux. But actually, if somebody's got problems with subtle issues with their upper registers and their vocal cords look ostensibly normal, the likelihood of that being due to reflux, I would say, is very small. But the problem is that when you look down with an endoscope, it's all very subjective. One man's mild bit of edema might be another man's absolutely normal, might be somebody else's kind of raging. So it's very difficult to objectively look at it. So I take quite a conservative view about managing reflux. I think if somebody's got rip-roaring symptoms of heartburn and acid brash, taste of acid in the throat and all that, then okay, fine, they might need to go on the PPIs, but I really, really try and steer clear of those medications if I can.
Gaviscon's all right though.
Gaviscon's fine, yeah, and that's absolutely part of my sort of standard advice, yeah, absolutely, yeah.
I just want to ask a little bit more about asthma.
Yeah.
I'm asthmatic and I came off my inhaler because of fears about what you discussed about sort of fungal problems, and I sometimes make my voice very sort of husky. But then I sometimes wonder about, because I don't have severe asthma, but like having a slightly less well functioning sort of respiratory system.
Yeah.
At which point would you, I mean, I use my peak flow meter to sort of check.
Yeah, well,
is there a point at which if you're not getting enough air out, that's going to be very bad as well? Or, do you know what I mean?
I think if it's so bad that you can't do a flight of stairs or cycle from here to the station, then yes, okay, that's a problem. Just from the point of view of being able to manage in life, I'm not a respiratory physician, so managing asthma is not part of what I would routinely do. And I don't think there is a single tipping point for when the lungs trump the larynx in terms of which is more of a risk to your voice. Long-term steroid inhalers can leave you prone to thrush. They can also leave you, they can thin the muscles of the larynx over time as well.
As an asthmatic sufferer myself, I mean, the way I've seen it is there are different products on the market, the different kinds of steroids, and you may want to speak to an asthma nurse or something about trying different.
And there are non-steroid inhalers that might be a better option, long-term ones.
And also, I was the most latest thing was given one inhaler it's called Trimbo, which combines several different inhalers I used to take separately.
Right.
Which is better. I suppose it lowers the risk of things like that.
I've seen that used in the last few months. So there was another question there. Yeah.
So at the beginning, when you were showing us the structure of the pods, and there was something called Rencke space.
Rencke space, yeah.
And you said some people lose it or don't have it.
Yeah. So if you you can't see Rencke space with just by looking with an endoscope, but you can infer that it is there and working well if that stroboscopy is showing you that the vocal cords are nice and pliable. Rencke space is there precisely to allow the vocal cord to vibrate smoothly. If you operate on the epithelium and you dig deep into the vocal cord down to the ligament, then as the area heals over, the ligament is going to be stuck, the epithelium is going to be stuck onto the ligament, so you won't get that smooth, pliable vibration, and you wouldn't see that nice mucosal wave. So that's the situation where you lose Rencke space. There are other situations where you can lose Rencke space in the absence of having had an operation, and then you lose pliability. So there's an entity called a sulcus where a little focal area of the vocal cord is tethered onto the underlying ligament, and then rather than the whole vocal cord being stiff, you might just have one particular area that doesn't vibrate so well. And there are ways of treating that surgically.
And do you know what symptoms people would show if that's the case? In terms of the sound of their voice?
Quite variable, but generally a mild degree of roughness, or a variable degree of roughness in the voice, and perhaps some breathiness as well. Because when in that situation, if you've got a little bit of if that vocal cord is normal and there's a little bit of loss of tissue on one side, then they're never quite getting the vocal cords together to come together completely. So you get a bit of breathiness as well.
Right.
So my lovely lady just sings as hobby, has always sung, and she's lost the top of her range and is a little bit hoarse because of what we think is emphysema, what she's been told is emphysema.
Right.
I just think if it sounds,
Has she got a deep speaking voice? And is she a smoker?
I don't think she would. I don't think so.
Okay.
And I wouldn't describe her voice as deep. No,
Right.
it's, but I just think if I can hear her thoughts coming together nicely within a nice range, she should just enjoy her singing. I mean, she's not a professional singer.
Yeah.
She's quite old.
Right. I think there's a pragmatic thing.
Yeah, there's a balance, isn't
yeah,
there?
absolutely. Yeah. No, I mean, I've shown you things going wrong in operations and goodness knows what, but actually, you have to work within, and if there are ways of working around a problem that don't require surgery or anything too aggressive, then yes, very much so. Yeah. So somebody else. Yeah.
Thank you. Steaming.
Steaming.
I think everyone being singers likes a hot shower, steaming, head over the bowl with a towel, old fashioned.
Yeah.
Is there a good on-the-go steamer or nebulizer or something, for airports?
There are various ones, and I saw various people have designed their own. So I don't endorse any particular one, and I think that actually a cup of water and breathing that in is as good a thing as anything, or turning the shower on. So I don't think that. Are you going to tell us about steamer?
No,
Right, another one. I think that anywhere you're inhaling through a straw from a kind of bubbling hot tub of water is probably not such a good idea, because that potentially is quite injurious. But no, I think just a general kind of waft of steam is the way to do it.
And should it always be in through the nose and out through the mouth?
I would tend to breathe in through mouth and nose, and then out through both. Yeah.
Okay. And a quick question, sorry. The nasal spray for hay fever.
Yeah.
Is there one that you would recommend?
The one I've found most effective over the last few years for patients is one called Dymista, Dymista, which is a combination of a steroid and an antihistamine, and hangs around in the nose, and by and large works very well.
Thank you.
Yeah.
Can I just about warming up the voice?
Yeah.
Particularly in the morning. I wondered to which extent is it more relevant to warm up your voice? Is it the muscular stuff that you've discussed around how it works, like the cricothyroid and all that sort of thing, or the actual body of the vocal fold itself that requires warming up?
Yeah.
No, it feels.
My instinct is it's more to do with muscular setup. I think it's to do with getting the blood flowing into the muscles, and actually getting your vocal posture, if you like, aligned before you launch into singing, rather than just jumping into it. The reason the voice is particularly problematic in the morning, or tends to be lower in the mornings, is that when you're horizontal, the vocal cords become a little bit swollen. That's why all of our voices are a bit deeper first thing in the mornings, and that eases off over the first couple of hours. For me, it's primarily about getting blood flowing into the muscles.
Can I just say something on that point? Do you know a guy called Ingo Tietze?
Yeah.
He's written some good stuff, particularly on warming up the voice, and perhaps the order in which to do it, in which to make things feel easier.
Yeah.
If you give me your email address, if you don't mind, I can send you links to all his books and his online stuff.
There's a lot of it. He's an American, I think, very, very prolific. Yeah. Maybe one more. Yeah.
Just wanted to share the fact that I've had the St. Blaise blessing with the 2 candles, but I can't attest to whether it did anything right.
Well, the Catholics will say it did, so there you go. All right, we'll pause there. Thank you very much indeed.
Thank you.